I'm so excited to welcome Tristan back to give us education on Peds Echo today. Um, he's Anna's BFF, so I don't think she's here today, but that alone should be enough recommendation. But he is also one of our former residents and completed his HEMONC training after graduating from residency and has been working at Seattle Children's. But I understand you're headed over here pretty soon, and that will be really wonderful for us. So congratulations, and look forward to welcoming you here in person. In the meantime, we're looking forward to learning about how our PCPs can support our kids who have been through bone marrow transplants and what to look out for and so on and so forth. So I'll hand it over to you, and I will be watching the chat. So if there are any clarifying questions or anything that might need interrupting in the moment, I'll go ahead and excuse myself and interrupt you to clarify. And otherwise, we can also save our questions or any cases for the end. So go ahead, Dr. Knight, and welcome back. And thanks, everybody.
Well, yeah, thanks so much. And just to confirm, you folks can see my screen, right? Perfect. All right. I'm just going to hide that. There we go. All right. So, as we said, I'm Tristan Knight. I'm currently in Seattle, but that will change in the near future. I have no disclosures of note. I'm part of the editorial board for Oncology Data Advisors, which has no relevance to this talk. And I will be discussing off-label medication use. So I figure the first thing I'll do is I'll kind of explain why I'm talking to you, as opposed to some random person in Seattle. So as Maya mentioned, I did my residency at CAP from 2013 to 2016. I met my now wife when I was in Hawaii, so we dated long distance and long term, and then we got married about 2 years ago on Big Island, actually. In the meantime, I did a pediatric hematology oncology fellowship at Children's Hospital of Michigan in Detroit after my residency. And then I went to Toronto to Sick Kids for a bone marrow transplant and cell therapy fellowship. I'm Canadian, so that worked out quite well. And then the latest news is that, as Maya mentioned, I'm actually headed back there. So this is actually, I agreed to give this talk before I had this anything lined up, but I'm going to be headed back to Kapiolani to join the group there. I'll be joining in January. So I'll have contact information to help with this. I'll be doing transplant over there. So this is very topical, very relevant. So at some point in the near future, we can change the little slide from Seattle Children's to Kapiolani. Learning objectives, as we mentioned here, we're going to talk about different kinds of transplants, the roles of transplants we try and do with those, to explore when we might be thinking about referring patients for transplant, including, how to, what kind of diseases we would need to transplant, to support awareness of the main complications after transplant, both in the acute setting, which is probably more, local, and the longer term setting, which is when you folks might be seeing them. And to recognize the role of gene therapies and how that's growing in the general population for pediatrics. Okay, there we go. So I guess the first thing is, why are we talking about this? Because I mean, it sounds pretty niche, and it is pretty niche. Transplant is a fairly niche topic. The reason is twofold. The basic reason is that transplant is growing in indication. This is kind of for the last couple of years. Folks are getting more and more commonly getting transplanted for various conditions. And about 15% of the transplants that we have here in the US are pediatric. So if you don't already have a transplant patient in your patient panel, the odds are at some point you will in the future. And I figured the useful thing is to kind of discuss what transplant looks like, to walk through that and to give you some of the language that we use. Because I mean, it's, being transplanters, we love using random acronyms and things, and it's not, there's no reason that people should know that because it's very niche and very specific. So I want to help us have that language that is useful. And, when you see our discharge summaries with, 8 different acronyms and all these kind of weirdness, what that actually tells you, and, the best way that it's, we can partner to ensure success at a transplant. And to basically honest to me to, apologize for how confusing we make it, because we make it very confusing. And some people don't even know we're making it confusing. My wife, she's a neurointensivist, when she has a transplant patient, she'll be like, why can't you folks just speak English? And that's a fair question. So this is to kind of help demystify this process a little bit. All right. So, oh, I should mention as well, I am at the hospital, so I've asked the team if they need me for any emergencies or urgencies to give me a call. So hopefully it won't happen, but there's a possibility of me being interrupted, in which case I'll come back to this as soon as possible. So fingers crossed. So let's start out kind of by talking about the kinds of transplants and the types we would do those transplants for. So there's two main kinds of transplant. There's autologous transplant, allogeneic transplant. We'll kind of get into why we would do one versus the other one. Auto transplant is pretty easy to conceive of. Essentially, what we do is we take patient cells from them, stem cells. We freeze them. We give high-dose chemotherapy to a patient, and we reinfuse the cells. We do that when we have conditions where the goal is just to give as much chemotherapy as possible. Because if you think about it, what is the main dose-limiting toxicity for transplant? It's marrow-aplasia, cytopenias and such. So by taking the cells away and then giving them back afterwards, we can give much higher doses. And for certain things like solid tumors in pediatrics, certain brain tumors, certain solid tumors, neuroblastoma is the commonest one, some lymphomas, this works very, very well, and we can achieve much better cure rates by doing this. But this basically, auto transplant, autologous, is self to self. The other main kind of transplant is allogeneic. Allogeneic transplants are different person to different person, where basically we remove the cells from a donor and we process them in some way, which I'll kind of explain in a bit, and we give them to a different person after they've gotten chemotherapy and infuse them. So it's basically someone else into you is allo, as opposed to being auto. Why might we do that? So there's a few main reasons we would want to do that. The first is to replace something that's broken or not working properly. So as you all know, I mean, bone marrow makes every part of our hematopoietic system, our blood cells, our red cells, our platelets, our immune system, our white blood cells. And if one part of that is not working, we replace it by doing a transplant. It can be a bit inelegant because if you imagine you have one cell line that's not working, say your platelets don't work, like a Glanzmann's thrombasthemia, which we do transplant for. Everything else works great, but you need to completely destroy the marrow and replace the entire hematopoietic system in order to fix that one part of the transplant. It's one part of the hematopoietic system. So it's a little bit like, feels like overkill sometimes, but it's the best we have for doing that. So replacing, platelets that aren't working. Red cells, same thing. Beta thalassemia, alpha thalassemia sometimes, sickle cell disease, hemoglobinopathies, basically where there's an difficulty making erythrocytes in some way, shape, or form, we can replace those. That's true of aplastic anemia, for instance, or marrow failure, where the marrow has just absolutely failed and is broken for some reason. Your Diamond-Blackfans anemias, your Shwachman-Diamond syndromes, or basically you have marrow failure for either a known or an unknown reason. The goal of transplant in that place is to replace the hematopoietic system, which is broken fundamentally. The other part you can do is replace the immune system, right? You think of our SCID patients who have, severe immune deficiency or who have some, immune problem, be that chronic granulomatous disease or some other major immune problem where they're just at, risk of dying from their infections. We can replace their whole immune system by doing a transplant. Again, it's a bit inelegant because if we could just replace the one part of the system, that'd be ideal. We wouldn't need to do the whole transplant. But we aren't there right now. Right now, the best way to fix one part of the hematopoietic system is to replace the whole thing. So that's the one main bucket. So you're doing allogeneic transplant to replace something. The other thing you can do for transplant is for malignancies. So malignancies are a little bit different. And the goal here is not to replace what's broken. It's to replace, or it's to give a new system, a new immune system. And that's for two reasons. The first one, which is kind of intuitive, is that you can give more chemotherapy by doing this. If you remember what I said about, the dose-limiting toxicity for most chemotherapies being to give a high amount of chemotherapy, that's true. I mean, we can give more chemotherapy that way. But realistically, that isn't what cures patients. We used to think it was. Back when this was invented a couple decades ago, we thought that the cure for transplant was actually the chemotherapy. It turns out that isn't actually true. What actually cures patients is what's called the graft versus leukemia or GVL effect. Um, and what that looks like, I'll kind of explain how the transplant immunology works a little bit, and then explain how that actually works. So what we do when we're looking at transplants is we look at the immune fingerprint, the HLA typing, or MHC, it's the same thing. Um, and we look at a patient's HLA type. You might hear us refer to HLA typing or having a patient sending HLA typing. That's what we're looking at. We're looking at this parts of chromosome 6 that control HLA ABC and HLA DR, DQ, and DP, these 12 regions that are very point-specific regions. And what we try and do is we try and find a donor who matches the patient as closely as possible at those points. Now, the chromosome is quite large, as you can see, and the HLA complex is very large. But by matching someone as close as possible at these 6 key points, we can make the transplant go as smoothly as possible. But there are other things that we don't look at called minor histocompatibility antigens, MHCH, where there's a little bit of a difference. And that difference, it turns out, is enough to generate what's called the graft versus leukemia effect, where basically what's happening is really cool. You are being cured not by the chemotherapy or by your own immune system, but by the donated immune system, by the new immune system you now have, where there are just enough differences in the cancer cells and the new immune system that those are recognized as foreign and your body isn't. And that means that your cancer cells are being attacked by the transplanted cells. And that graft versus leukemia effect is what actually cures someone. And we know this because if you do what's called a twin-to-twin transplant, so identical twins, it's called syngeneic transplant. We don't do those because, and we found this out kind of the hard way back in the 80s, 90s. Those patients have identical immune systems, right? Identical twins, right? They have the same everything, same donated, same genes, same HLA, everything's the same. Those do not cure patients, but matched sibling donors who are pretty close, same parents, right? The same inheritance. Think of the Punnett square thing, the 2x2 thing where you have same chromosomes and everything. Someone who has the same HLA complex chromosomally, but is genetically a little bit different, that is enough of a difference that they can be cured. So we know for a fact that what actually cures someone is not chemotherapy at all. It is the graft versus leukemia effect. Now, the problem with that, and the flip side to that, is what's called graft versus host disease, which is what it sounds like. It's the graft you've transplanted attacking the host, graft versus host. And that is the main complication of transplant. Talk a bit more about that in the future. We'll come back to that. But the way to think about that is exactly that. The donated immune system is recognizing not just the cancer cells, but the host's body as being foreign, right? The cells are taken out of the donor, they're processed, they're infused, and they wake up in the donor and they say, wait, this isn't me, this is the wrong place. And they attack the recipient, the host environment. So that's a major complication. We'll explain kind of more about that, but that's the flip side. And one of the holy grails in transplant is teasing out the ways to get graft versus leukemia effect, which you want and which cures you, versus graft versus host disease, which you don't want, which can kill you. Ideally not, but it can. And teasing out how to do that is, an active area of research in many, many places. And it's kind of a very nuanced thing, like how you kind of do that. All right. Yeah, so this is kind of what I was talking about here with the GVL effect, where you have the donated system here, and you have the donor T cells attacking either an AML cell in this case, which we can transplant, attacking that, or attacking a healthy patient cell. I'll pause here and mention the kinds of malignancies we transplant. So leukemia is the commonest one. Relapsed B-ALL or T-ALL, that's the commonest, one of the common indications. AML, when you have certain genes, certain genetic aberrations, that is also a common reason to need to do transplant. The liquid tumors, as they're called, liquid malignancies, the leukemias, are the ones that are amenable to this kind of transplant. Solid tumors are not really fixable with this kind of transplant because there are too much of a microenvironment, too much of a big tumor that's there where you can't really get this immune cells to go and attack the tumor, there's just too many cells. They can't do enough. It's imagine if you have like a huge abscess, your immune system can't clear that. It needs help. And so this kind of transplant only works for liquid malignancies, leukemias for the most part, and some lymphomas, which are not that bulky. So where do we get donors? How do we get donors? What are the sources here? There's three main types, and we have them here on the screen. So the first is called apheresis. And if you've ever donated blood, it's basically that process. You have what's functionally a centrifuge. One tube is taking out the blood from the patient, other tube is getting it back. In between there's a centrifuge, it spins really fast, and you have a layering effect where you have the platelets, or you have the plasma at the top, it's the least dense, then platelets, then white cells, then red cells. And what you do is you adjust the intake for that, and you can pull off the white blood cells, which are what you actually want. And in that white blood cell population, there's a very small number, about 1% or less, of stem cells. So you process this and take this, and that's what you can infuse. That's called a peripheral blood, PBSC, peripheral blood stem cell. We tend to use those as our default because, as you can imagine, it's pretty easy to do. You go in to a blood donation center or a hospital, you have this done, you leave. It's pretty straightforward. Often what we'll do is we'll give GCSF to stimulate white blood cell production and stem cell growth. So we have a better chance of collecting enough cells in one session. If we need to do two, we can do that. But it's pretty straightforward, honestly. It takes a few hours maybe, but it's pretty easy. That's our main source for donations at this point. It used to be this kind of middle picture here, bone marrow donation. Now, it's a bit tricky. I mean, like, it's called a bone marrow transplant, right? So you'd think bone marrow is what we're using. We now use more peripheral blood stem cell transplants because the stem cells are circulating in the body. Bone marrow is going to the source. This is a picture here of a patient lying face down. The needles are going into the posterior superior iliac spine back, right at this, on the pelvis there. That's where we harvest bone marrow from. You basically have exactly like this. You have one transplanter on each side. It takes a couple hours usually. You're taking off, between 10 to 50 mLs of blood and marrow from the patient every time you pull it out. It's very, very hard to do. It's a lot. It's a very, you're pulling from marrow, so it's not a simple process. The patients are anesthetized, they're asleep for this, they may need to be admitted to the hospital afterwards. It's a much more involved process. And you need to process this marrow a lot more because, as you can imagine, there are bits of bone in there, which you can't transfuse to a patient. So it's a much more involved process, and most transplants don't actually involve this anymore because it's such a big ask for the donor. Because again, most donors, if you think of them, they're altruistic. They're either unrelated or maybe they're a family member, but if this is a major risk to them, it's a sedation, it's a procedure. So we try and avoid doing this when we can avoid doing it. In certain circumstances, though, we do have to do this because there are certain kinds of disease where you have better outcomes with this kind of transplant. Aplastic anemia is the specific example where this kind of transplant, the bone marrow transplant, we know works the best, versus for cancers and such where apheresis, peripheral blood stem cells, work the best. The other type of transplant is umbilical cord transplants. You'll see it abbreviated as UCB, umbilical cord. And that's what's happening in this picture. They're harvesting cord blood from a patient. So after the cord milking is done, or not cord milking, so the delayed cord clamping is done, there's still plenty of stem cells in those cords. And so we collect a amount of them and we freeze that, and they're able to process this and store this so that when we need to, we can give these cells back to a patient. This is a useful way of doing transplant because these cells are very immature, as you can imagine. They're literally brand new. So the risk of graft versus host disease is much lower for these kinds of transplants. However, they aren't as effective against leukemia or cancers because there's not much of an immune system there. They're literally newborn immune systems. And they are also pretty naive as far as the number of immune cells there. So they have a higher risk of infection after the fact. So there's various reasons to choose these, but you'll see them either referred to as a PBSC, a BMT, or a UCB transplant, respectively. And the reasons for that tend to relate to whatever the transplant was done for. And again, if you're ever curious about that, we'll always have a reason why we chose a certain kind of donor. And just feel free to ask myself. Well, actually myself, it'll be me. if there's a reason you want clarification about why we chose a certain kind of donor. So the process itself, I figured the useful way to kind of explain how a transplant works is to just walk you through it. So the first thing that happens, before even actually this part here, is that a referral is made. So you have a patient, they have cancer, or aplastic anemia, or immune dysregulation, or something that needs a transplant. You talk to us and start a process for workup. Now, depending on what the condition is, they may be at home, they may be seeing you, they may be on Oahu at CAP. It's hard to know depending on what the transplant indication is. What happens is we do what's called HLA typing. Remember, again, thinking back to that slide with the HLA types, which gets sent off to the National Marrow Donor Program, NMDP. And they use this huge algorithm to search through the tens of millions of people, I think it's over 100 million at this point, who are in this database. They look at all the different sources at the same time, umbilical cords, peripheral blood, bone marrow, all these things. Those little swabs that we do at kind of collection points, they look at that. And you try and find someone who's as close a match as possible. Now, the HLA genetics are such that the more homogeneous the population is, the better chances of finding someone who's in an HLA or immune system match. So in Japan, for instance, which is a fairly homogeneous population, your odds of finding a fully matched donor are very good, 90% plus. If you are white Northern European and non-mixed, your chances are about 80%. And the more mixed the population gets, as you can imagine, the harder it is to find someone who's a fully matched donor. So in Hawaii, this is kind of a unique challenge because obviously it's a very mixed population. And if you imagine, so myself, I'm fully white. My wife is Japanese, Asian, Japanese, Chinese, and Portuguese. So if we eventually have kids, those kids are going to have a very hard time finding a transplant match where they ever need one because their immune system is this amalgamation of all these different racial groups. So the more homogeneous the group is, the easier it is to find a match. Once we find a match, if we can't find one, so we get a data report back, give us our options, we choose one, the best one for the patient, and then we transplant the patient based on that one. If we can't find someone, often what we'll do is proceed to what's called a haplotransplant, which is haplo half, your haplotype. And those are basically usually parental or sibling transplants because those patients, every patient, has a half match by definition somewhere in the world because you have a parent, right? But everyone has their parents available. But by definition, half of your HLA group comes from your parents. So you can do a half match transplant if you need to. They're safer than they sound because we use medications to specifically reduce the risk of GVHD afterwards. This kind of an active area of research is how you optimize this kind of transplant. But it's always it's not a last resort, but it's not our first choice if we can find a better match than that. So we kind of do that. Next up, after we've sent the referral and we've matched someone, we choose what's called a conditioning regimen. So the conditioning regimen is just the chemotherapy that we use. And depending on the kind of transplant we're doing and the reason for it, we might choose different kinds of conditioning regimens. From the fully myeloablative, which is just the high dose everything, where you just delete the marrow and everything else in it, to reduced intensity or non-myeloablative approaches. Now, if you think about it, if someone has a aplastic anemia and there's not much in their marrow, you don't need to do that much, really, to get rid of whatever is there, which is mostly just kind of residual lymphocytes and such. So you can do a pretty non-myeloablative approach. And that's a benefit because you have less toxicity, less side effects from the transplant. Versus someone, say, who has sickle cell. Those patients need a full myeloablative regimen because their marrow is working just fine. Their immune system's fine, everything works great, except that they have sickle cell. So you need to be very aggressive with those kind of patients because if you don't, you're not going to have enough of a, wipe the marrow clean enough to transplant them. So the regimen we choose depends a lot on the patient's disease, also a little bit on their conditions and their health status. So say you have someone who has a very weak immune system, you don't need to give much. But say you have someone who's going to have a high risk of rejecting or not having their graft work because you have someone who is, has liver failure or kidney injury. You need to choose a regimen that is very specific to that kind of approach. So it depends a lot on that. They have Transplant. This is from the National NMDP database. This is not a patient of mine, but this is what bone marrow looks like. You would not be surprised. You'd be very surprised, I think, to see that it basically looks like a blood transfusion. I mean, that is their marrow, right? So most patients think of it as being fairly anticlimactic, that it looks like a blood transfusion, because honestly, it kind of looks like one. They've asked me before, like, is that it? And yeah, it's given through a central line, just because that way we'd have less risk of it, not working. And the stem cells themselves are very smart. They know where to go. They home into the bone marrow niche as they're circulating through the body, and they stick there and they stay there. So there's no actual marrow directly involved in marrow transplant process unless you're drawing the marrow out of the donor. We don't infuse into the marrow. We don't, do any kind of manipulation of the recipient marrow. It literally is just a blood transfusion functionally. And the stem cells within that know where to go. It's very kind of cool that way. Afterwards, this is the tricky part, one of the tricky parts. This is where we have about a 2 to 4 week period of no immune system, and your risk of infection is very, very high. You also have other side effects that can happen at this point. We try and control for and minimize them, but this can be a very tricky time in transplant. Having no immune system, it turns out, is not great for you. So your infection risk is very high. Your risk of transplant associated comorbidities and injury from various chemotherapies is very high. So this is certainly something we are watching for and can happen. After the transplant, though, we follow what's called chimerism. I put this slide in here because this is the chimera. This is a Greek, creature. It's the head of a lion, body of a goat. I don't know if it has 2 heads, but it does, and the tail of a snake, the chimera. So we track the chimerism after a transplant, and that's because we're looking for the chimera, basically the donor versus the recipient. More is always better. We want to see 100% at least of donor and no recipient left in malignancies. It matters a lot less in things like sickle cell or immune dysregulation, things where you have no immune system, because if you have half an immune system, that's still better than nothing. We like it to be higher than that, but it doesn't need to be 100%. That's true for sickle cell disease as well. You don't need to have full, donor chimerism, but more is always better. So we do track that, and you'll see that in our reports. 100% or 50% or whatever donor chimerism, and the goal is always to have high chimerism. Post-transplant, GVHD, as I mentioned, this is the big one. This is a complicated slide. You don't need to know this in detail, but I mentioned it because this is kind of a good schematic how to think about this. So what happens is there's conditioning that happens, chemotherapy. It damages the body. The donor cells come in, they wake up, they see the damage, and they start targeting the organs that are damaged. And those organs are threefold: the gut, the skin, and the liver, which is, if you think about it, those are the most immunologically active parts of the body. That's where we see problems. So you have this kind of period where you have this rapid onset period early with acute GVHD, which kind of tapers off, and you have then more of an autoimmune-like condition where that evolves into chronic GVHD over months to years. Acute GVHD is something we see in the hospital. You won't see these patients outpatient. You shouldn't anyways. Where we see skin and liver and intestinal involvement, which looks like skin is a rash, which I have here. So it's a pretty specific rash for transplant. Again, you won't see these patients outpatient, but this is in the hospital setting. It can be progressing to full discrimination. It can be very, very bad. This is actually fairly mild, this one here. Liver looks like liver abnormalities, liver injury. Intestine looks like diarrhea or poor intake because of the attack on the donor immune system versus the new host. Chronic GVHD, this is a busy slide. I just put it up here to kind of give you an idea of what we assess for. Chronic GVHD can literally involve any part of the body, any organ system, anything at all. And the reason of that is because it's functionally an alloimmune condition, right? It's the alloimmune system, the new immune system, attacking something. So the way to think about it is that there's a risk for it created by the transplant, and literally what you can have next is anything. So I'm going to tap through these slides really fast, but that can be skin involvement, that can be mouth involvement, which also some pictures here. There you go. So that's skin involvement, any kind of weird manifestation. It can be hair loss. It can be kind of a sclerotic looking picture. The mouth there you can see is lichenous planus, and oral dryness. These are certainly things that we can see. So these are things that you may see in the outpatient setting. So any new rashes, any oral dryness, are always worth calling about because that can be GVHD starting. GVHD can start at any point after transplant. The risk is highest earlier on and tapers off later on in life, but technically can happen at any point. Usually it's the first couple of years. It's not usually like, 20 years down the road, but it can happen technically at any point. So any new rashes, things you're worried about, always happy to call. The eyes can be involved. Eyes looks like dryness for the most part. Um, Dry eyes, itchy eyes, blurred vision, these things. It can progress, and I have seen it progress up to blindness because of how severe it can get and how badly the cornea can be injured. That is not common, fortunately, but it can happen. So new things like dry eyes, eye complaints are always worth referring. We usually have ophthalmology see these folks and put them on steroids as an eye drop to help control that. The GI tract, same thing. It can be non-specific. Weight loss that's not clear, loss of appetite, nausea, vomiting. These tend to be more acute, but it can happen at any point. Same thing, liver injury or liver abnormalities that aren't explained. These are always things worth chatting with us about because that can also be a sign. Basically, any kind of abnormality like that is worth talking. This is kind of the other indicators. So as you can see, this is literally a bunch of stuff. This is neuropathies, this is pleural pericardial effusions, this is ascites, this is nephrotic syndrome. There's no easy way to distill this down, but to say that literally any organ system can be involved. Our process is usually to do a biopsy to confirm that there's T cell infiltration here, causing the damage and the injury. The skin involvement as well, one thing we always check for is range of motion. The skin and the joints can become very severely affected, where basically you have sclerosis and joint restriction happening. So if you can see here, you can have folks from 5 or 4 or 3 being normal, all the way up to not being able to bend their arms or shoulders or wrists. It can be, basically very, very constricting and very debilitating for these folks. This can see the joints and fascia being involved here. You can have lung involvement, which can look like mild symptoms all the way up to lung failure. These folk can and do occasionally need lung transplants because they have lung being attacked by GVHD. We watch for this closely with pulmonary function testing, but it's always a possibility. The genital GU tract, in females, this can look like vaginitis. In males, this can be phimosis. But we have people who end up needing to be on intravaginal, or penile steroids because they need to control the inflammation in that area, which is obviously not comfortable, but it can certainly happen. And it can also have any combination of organs. It's not, always involve the skin or the eyes or the gut. It can be random combinations, and we don't really understand why it involves certain combinations of joints, of organs, but the management we use will depend on how severe and the degree to which it's debilitating. All right, so I'm going to keep going, but again, we'll come back for questions at any point. This is the next major complication after transplant after GVHD. It's relapse or graft rejection. Now, this is kind of a cool image that conceptually shows what's happening here. So when you have cancer initially, you're starting from the left, going to the right. You have one clone that takes over and predominates. That clone mutates, and you have other colors develop, these kind of purples and blues and yellows and stuff. When we give chemotherapy, we end up deleting most of those cells. But as you can see, there's this little tiny green bit that comes along here, persists through therapy, and then expands out. And so we can see changes in the actual type of cancer or the genes that are present and causing the cancer if you don't eliminate all the clones. So I mention that because any kind of cytopenias after transplant will always get our attention because that's usually how we pick these up. Is it someone who is, 2 years post-transplant and been doing great, and just all of a sudden out of the blue they come in for a CBC, and their white count used to be 5 or 10 or whatever, and now it's 2, and their platelets a bit low. Maybe platelets used to be 150 or 200, now it's 100. Hemoglobin's a bit low. That's a red flag, and that should always, get us involved with that, because that can be the earliest sign of relapse, or less commonly graft rejection, where the graft is starting to fail, which is caused by the host's immune system kind of reactivating, waking up. Somehow it's persisted and attacking the new immune system and starting to win. So we can deal with that when we pick it up, but that's what that looks like. It's cytopenias out of the blue. This is something that is important as well, reimmunization. The way to think about this is that after a transplant, your immune system is starting from scratch. Even if you have someone who is an adult donor, say you have a parent donating to a kid, that adult is fully immunized, has seen all kinds of infections and stuff, but the stem cells have not. The stem cells are not causing immunity. That's, your memory T cells, your B cells, your plasma cells, whatever else. The stem cells have no knowledge of that. So it doesn't matter who the transplant comes from, they're always starting from zero with their immune system. As a result, we need to reimmunize from scratch, which, sucks if you're, 5 and had just gotten through them all, but happens. We delay immunization through about until about 6 months. At that point, we think the immune system is kind of alive and awake enough that can actually respond. Before then, we don't think of it as being active enough to respond. That's kind of a moving target, because if you're still on immune suppression medications for graft-versus-host disease, your ability to respond to a vaccine is going to be very, very impaired. So it's kind of a moving target, and we'll certainly help direct this and guide this. You aren't expected to know this off the top of your head. This is not something we can be like, go be free and, revaccinate. We help guide this because it's a complicated kind of conversation about when the optimal timing is to ensure that you actually have a good response to it. We also recommend avoiding live vaccines until at least 12 months, often 24 months. Same as for, an infant, where we try and delay live vaccines because they're at risk of actually having vaccine-transmitted disease. Same kind of concept. The best way to think of these kids is that they are a 5, 10, 20, whatever year old with a neonatal immune system. And if you think of that, it's exactly what's happening. That's the honest reason. The COVID vaccine there and the influenza vaccine as well, I mentioned briefly. Those are ones we do early on because if there's any response to that, that's better than no response. And both being very prevalent, obviously, in the community, there's no downside to doing it, but it can be helpful. If there's any immune response at all, it's better than none. So that's why that's unique there. But you're not relying on that for long-term immunity because you're going to be revaccinated probably every year. That's the way things are going. Late organ dysfunction. This is basically the long-term side effects. I'm not going to run through this in detail. The slides are available if you guys want to review these in depth. And I think Summer's going to send out the document this is from. But basically, these are all side effects that arise because you have given tons of chemotherapy, radiation in many cases. You've been on medications for the long period of time, the calcineurin inhibitors, which help prevent graft-versus-host disease. All these medications where basically you are causing long-term side effects. And so we monitor for them closely. These folks have an annual visit with us at CAP to watch for these exact things. We don't feel it's fair to, say, good luck, and have the kids go out in the community because, these are things that are very specific to transplant in many ways. Not everyone's going to have these exact complex of symptoms or of late effects, what they're at risk for. It'll depend on what they've been given. And so again, we'll help guide this because, we'll be able to help guide what we're looking for. And, after discharge, look at a summary that's it basically says, patient got these medications, they're at risk for these side effects. These are the recommendations for monitoring we'd recommend. And we'll help guide all of that. So you're not just on your own for that. And we're always happy to chat about what late effects to be looking out for. Yeah, so I'll just mention as well, the risk of secondary malignancies is non-zero. We don't like seeing that, but it can happen. Some of these agents are in themselves carcinogenic and can cause secondary malignancies in folks, which sucks when it happens. It's not a high risk, but I'd say the risk is probably about 5% of having a secondary malignancy caused directly by the chemotherapy that they've been getting for the transplant. Switching gears entirely. So now we're leaving transplant behind, sort of, and going to gene therapy. So you might be like, why are we talking about gene therapy? We're talking about transplant. And it's because, it's a good question. It's because gene therapy is related to transplant in many ways. And we're going to be doing more and more of these. There's currently 3 approved, FDA-approved products for this. Two for sickle cell and 2 for beta thalassemia. And these are functionally kind of like transplants in some ways, but kind of not. And so what these do, they're very cool. What we do is we take the patient's cells, sickle cell or beta thalassemia, we manipulate them in some way. In some cases, we upload, we use lentiviruses. If you think about how lentiviruses work, right? They're retroviruses. They upload their DNA into the host. We adopt that and load those viruses with a normal copy of hemoglobin we actually want them to have. And we infuse those cells back into the patient. And so we cure their sickle cell or the beta thalassemia that way. The other way we can do it is we can use CRISPR-Cas9, which is very selective, and we can use that to manipulate the genome of the patient to cure their disease. Really briefly, so we don't actually delete the sickle cell gene, the hemoglobin S gene, or give them a new copy of hemoglobin A. What we're doing is we're disrupting an off switch. So we're turning off an off switch. So if any folks have sickle cell patients, you may recall, using hydroxyurea and that they have a high hemoglobin F. Hemoglobin F is protective against sickle cell. So what we do is we turn off the downregulator for hemoglobin F. And what we do is we create a state where we basically have 50% hemoglobin S, 50% hemoglobin F. And that's good enough that they don't have sickle cell disease anymore. It cures them. Or in the other way we do this, we upload a different copy of hemoglobin A in, and this T87Q thing, that basically is a gene, that's the part of hemoglobin A that prevents sickling. So we're basically uploading hemoglobin A that is like super anti-sickle into these patients. So I suspect that as we start doing more and more of these, you're going to start seeing more and more patients in your panels that have this. I don't think it's going to be common because this is a very expensive, very involved therapy, but it's not out of the realm of possibility that you might be seeing these patients in the next few years. And there's going to be more and more of these conditions that we have cures for that are gene therapy. The way this works, though, we admit these patients to our hospital, to CAP, and we do this therapy inpatient by deleting their immune system completely. So they're admitted for a month, for transplant. And they have all the complications of transplant during the hospital stay, but they come out the other side and they have no risk of GVHD, right? Because this is their own immune system. They have no risk of graft relapse or failure because this is their own immune system. They have no medications besides preventing immune system from being there. They do have the risks of, brand new immune system because they don't have their immune system has been deleted. So that's all there. It's kind of like a half transplant as far as their complications go. But yeah, this is a really cool concept. They are going to be more and more of these conditions that we can cure this way. That'll be transplant adjacent, I would best phrase this. With that, that is the last part. Summer, we can go to either MOC questions now, or we can do Q&A, whatever works best for you. I'm not sure how we usually run things.
I don't see any questions in the chat, so I will start the poll. And in the meantime, if anyone has questions, please feel free to unmute or drop them in the chat.
Cool.
Thank you, Tristan.
No worries. And then we can talk through these answers if anyone has any questions. But so how does it work? Do we folks choose questions and then after a bit I'll go to the next slide and show the answers, or how does that work?
We kind of just give them, depending on how quick the answers come in, some time to answer it. And then if there's any question that there's a large variant of answers, we can go over it. We'll see.
Yeah. Okay. And I'm realizing I actually didn't talk about this question. I apologize, folks. Tandem transplant means you do more than one. Just a hint. So yeah, tandem transplant, we use this for neuroblastoma, especially because it's kind of like if you give one transplant, 2 is better. And we've proven that very conclusively, that tandem transplants, double transplants work better for basically every condition where we do auto transplants for. So that's brain tumors, that's neuroblastoma. So you'll see them referred to as tandem transplants. That means they had more than one transplant. Yeah. So I should have added that as an actual point.
So we only have 4 answers so far, so we'll give it a couple, like a minute or a minute and a half more. But we do have a couple questions as well. One is in the chat. So maybe you can just
Yeah.
ready to answer that after we go over the answers to the questions. And that is whether patients with GVAD are more likely to develop metastatic cancers. And so I'm assuming that
Mhm.
means secondary cancers that are
Mhm.
metastatic.
Yeah.
So maybe we can just, oh, sure, go ahead and answer it while people are doing questions. That works too.
Sure, yeah. So basically, your secondary cancers tend to be one of two forms. They're either leukemias, which is by definition metastatic, it's everywhere, or it's a localized tumor and not metastatic. So it's not exactly an easy answer to say because they're usually brain tumors or skin cancers or sarcomas. GVHD in and of itself doesn't increase your risk of having a metastatic cancer, but it increases your risk of having skin cancers in particular, because if you imagine how you have this kind of chronic state of active inflammation, that drives proliferation and can drive malignancy. So GVHD is a major risk factor for skin cancers specifically. Not for other kinds of cancers per se, but yeah, skin cancer, absolutely. And that's all kinds. That's BCC, SCC, melanoma. So if you've had or have active GVHD of the skin, definitely a higher risk for skin cancers. Good question, though.
And we have just about half, so I'm going to go ahead and end the poll, and we have some time, so maybe, yeah, if you want to go through each
Yeah.
of the slides, thanks.
Happy to, yeah. All right, so yes, the next one, so yeah, as mentioned, so a tandem transplant is one where they have had more than one transplant sequentially, and auto is themselves as a donor. So a single transplant using a sibling as a donor would be a allogeneic transplant, and that could either be a matched sibling donor or that could be a haplotransplant using a sibling. Single transplant using a parent as a donor would be an allogeneic transplant, and that would be a haplotransplant by definition, because if you, again, think of the haplotypes, you're getting half of your type from mom or dad, so that would be a haplotransplant. All right, we'll keep going. Yeah, there we go. So patient's conditioning regimen refers to what?
You can go through the answers.
Cool.
Everyone answer.
Oh
Yeah.
yeah, I see. Gotcha. Yeah, they're everyone's answering. Good. Got it. Yeah. So the chemotherapy before transplant, yeah, that is the conditioning regimen. And it'll usually be full of acronyms and stuff, and we're happy to clarify what that means, but that's dependent on the actual disease present. Yeah. Q3, if they've had a haplotransplant, what does that mean? And that generally means it's a parent, yes. Identical twin, as we said, is a syngeneic transplant. We don't use those almost ever because it doesn't work for malignancy, because it's same self to self basically. And even for conditions where there's marrow failure or whatever, if they're identical genes, you wouldn't be trying to fix the gene defect or marrow failure or whatever with that. So it's almost never done. Q4, GVHD can involve which of the following organs? And exactly, it can involve literally any organ. All right, very good. This is the lithography here. So if anyone wants to see those. And then I'll close and say thank you so much for this. Been glad I could talk to you folks. My email information is there as my cell phone and my email. So again, I'll be taking over the transplant program starting in January. So any questions about any of the kids who've had transplants, always happy to talk. There's no silly questions. I'm always happy to answer anything I can answer. Text, call, whatever. And if I don't reply to you immediately, I will get back to you as soon as I can.
Thank you. That was a wonderful talk. I did have another question or two, and of course, folks, feel free to put questions in the chat. We still have about 8 or 9 minutes left. So you were talking about late graft versus host disease, and I'm not a PCP, but it struck me that if you are a PCP, it might be really hard to know whether your transplant patient is sick or not sick.
Yes.
Or if you should be calling the oncologist, or it's just a nothing that we normally would say, you know,
Yeah.
supportive care and come back in a few days if you're not better. So there's like, that's the general question. The specific one is, what about darker skinned individuals? Are there particular features of the rash that in like more pigmented
Yeah.
skin, you could share screen and show us so that we would have like a better understanding of what might be, you know, set off alarm bells for GVHD in a darker skinned patient?
Yeah, absolutely. So I'll go in order of asking. So I'll quote one of my mentors from Toronto, which is that if you're worried, make me worried too. Don't worry alone. There are no dumb questions. I mean, like transplant is like about as niche as it gets in pediatrics. I mean, it's very specific, and I mean, you know, I don't expect people to try and figure out if the patient is sick. If you're worried, call me, or email, or whatever contact system we have for CAP. You know, that's why we have a system, because, you know, it's, you know, I would not, Anna and I were talking about this. I would not be good at working up someone who has a UTI anymore, because it's changed and it's evolved. You know, and, you know, it's not unreasonable to talk about these things and these kids. I mean, I get calls from folks who had transplant, you know, 10 years ago, and that is always reasonable. I mean, we're always happy to talk. Yeah, we don't, you know, this is a very niche area that has a lot of areas where things can go wrong. We try and see these patients long-term care, but I mean, obviously, you know, if you're 10 years from transplant, you're not being seen except for maybe once a year, if they're even still being followed. If they, you know, sometimes they get lost to follow-up sometimes, unfortunately. But yeah, no, if you're worried, just reach out. So there's no dumb questions. They're all good questions.
Very reassuring answer.
We
'Cause
try.
I feel like I would have no idea what to do.
And that's, yeah, exactly. I mean, there's no reason you should. I mean, it's like, you know, people, we might, you know, you might have had maybe one patient, maybe no patients ever who've had transplants during training. And since then, like they're not common patients. They're gonna getting more common, but they aren't common patients. So yeah, it's always good to reach out.
Thanks. And
No worries.
the
And
other
then,
one,
yeah, and then for darker skinned individuals, it is hard. I don't have any pictures saved here, and I did try actually, because I figured this might come up. But GVHD is a rash you can feel before you can see it. It's a roughening of the skin, and it's a thickening of the skin. I think that the process, right, it's basically it's T cells invading the skin and causing a local inflammatory response as they activate. So what I can often do is, when I'm checking for patients, it's usually like the neck, under the arms, where the skin is already thicker. And you can kind of feel this roughening of the skin that's there before you even see the redness happening. So, you know, checking those areas, if the patient's complaining of anything, I mean, they'll complain sometimes of either painful skin, inflamed skin, itching. So if you have, you know, a very dark skinned individual who's never had sunburn in their life, and is suddenly coming to you and saying, yeah, my skin itches, you know, to me, that's usual, because that's, you know, I sunburn. But, you know, to someone who's super dark and who has never sunburned in their life and had a transplant, you know, and suddenly their skin's itchy and feels like tight and just painful, that'd be worth calling about for sure, because I mean that is, until ruled out, that's GVHD. Even if there's no actual redness, you know, that can certainly be, it's felt by the patient and by you before it can be seen. But it is a challenge. I mean, it is a red rash, and in someone who's got darker skin, it's harder to pick up for sure.
So when you say it's like you can feel it before you see it, is it sort of like the sandpaper rash of scarlet fever, or?
Very similar. Yeah, very similar.
Okay. Yeah. And Renata asked about acanthosis nigricans, but you know, I think that would be different because of the it's like a dark pigmentation as opposed to erythema. Is that right?
Yeah. But yeah, again, it's like it's one of those things where taking pictures of it with phones, I mean, most of us have phones at this point we can do pictures with, you know, by email, by, you know, just texting them to me or whatever. It can be easy to look, but it can be, I mean, it is hard to distinguish from certain rashes. Acanthosis is certainly one of them, because I mean, it's involves similar areas too, right? I mean, the neck is certainly one of them. Under the arms, it's the thicker parts of the skin, which is exactly where acanthosis happens. So yeah, good question.
Yep. Okay, any other last questions? We just have a couple of minutes. Maybe you can tell us when you'll be starting, because that
Yeah.
would be very good to know.
Yeah. So the timeline tentatively would be starting January 20th. There's credentialing, which is obviously everyone's greatest delight. I've got my
Yes.
license already, so that's good. But yeah, tentatively I'll be starting August, I wish. July, I'm sorry, January 20th. My wife will be starting her job in July, but I'll be starting out in January.
Okay, all right. Well, we're very excited to have you back.
Yeah, glad
So
to be there.
yeah, that's fantastic. And then before we go, I'll just mention that we'll be having Dr. Marian Mellish presenting on measles, and also including some discussion of things that look like measles but aren't, especially with measles outbreaks here and there around the country, with decreasing rates of immunization, especially on Maui. I think it's only a matter of time until we have a measles outbreak, and with it being so contagious, we thought this was a very timely topic. So that will be next time on September 18th, and I recommend that you all come and tell your friends. And also wanted to let you know that we're going to be piloting a later start time in October. We polled a bunch of you, and we also did some informal polling amongst our colleagues and friends, and it seemed like the consensus was that maybe a 12:30 to 1:30 slot would be better than a 12 to 1 p.m. slot. So we're going to try that out for a few months starting in October. And then if it's not working for you, please do let me, Anna, or Summer know, so that we have a good sense of if we should be switching back or if people mostly like the later start time. And Kelly, I see that you turned on your camera. Did you want to say anything or just saying hi?
Just thank you and hi.
That was a
See you.
great talk. All right, folks.
Agree.
Yeah, thank you so much. It was a very educational talk for, for folks like us who don't have anything to do with transplant. It was a really nice overview. So yeah, thank you. And everyone have a wonderful rest of your week. See you in 2 weeks.
Thanks all.
Thank you.
Bye.
Bye.
Thank you.
Kristen.